Hello and welcome to Arbor and Aspen's documentation standards. We'll be reviewing our benchmarks for quality treatment and progress notes. So we can't overstate the importance of the high quality of the documentation we provide. It gets us approval for continued therapy when we can show the sophistication of the interventions that we're performing. It can help protect our licenses to make sure that we are operating within our standards of practice. It helps us adhere to professional standards for the ethics and integrity of the information that we're providing. It records the sophistication of care that we're performing or providing. So we all know that we went to college and we have degrees to enable us to do what it is that we do. We want to make sure that our documentation reflects our smarts, so to speak. And when we do that, we're going to be minimizing our risk for denials, helping promote our reimbursement for the services that we've been paid for through our employers, and now our employers deserve to get reimbursed as well. It helps us from a liability standpoint. As you know, if it wasn't documented, it didn't happen, or perhaps it did happen, and we want to make sure that our information is going to cover everything that could be looked at, especially in the situation where a person might be injured. And we also want to have solid, strong team communication. We know that sometimes we don't always get to spend a lot of time together, so we may be reviewing each other's entries, and that helps us have good quality communication and carryover when we've got that quality of our documentation. So within the daily notes or our treatment encounter notes or TENS, those are to be done on a daily basis for that day's billing. The best notes are really going to be a combination of the billed phrases and some free typed patient-specific data showing specifically what treatment you provided and how they did with that intervention. What was their response? In addition to Min, Mod, Max, Assist, was there fair carryover, good carryover, poor understanding? How did that look for them in terms of their response to the intervention? And reminder that students may not document on the patient chart, and this is per CMS regulations as well as our company's policies. They may document in the sandbox and do mock notes, but not within the patient's medical record. And again, that is a legal record. With billing in the treatment encounter note, you want to choose the CPT billing codes for what you did each session. So be careful not to lump all of your interventions under one or two CPT codes. So for example, you don't want to be billing gait under therapeutic activity or ADLs under therapeutic activity. You want to separate those out. Remember the 8-minute rule that like 8 to 22 minutes counts for 1 unit. Bear that in mind, and you can ask your FRC for more information if that's not familiar to you. And you want to make sure that you don't repeat the tasks under two separate billing codes, because that could appear that you're double billing, and you want to be careful that you show the specifics. So for example, if you're providing balance retraining and you bill 97530, which is therapeutic activity, don't repeat balance retraining under neuroreeducation 97112. Show how they're different, what you've done differently. If you're doing transfer training for both toileting and, for example, a chair to bed transfer, you want to be careful if you're billing 97530 therapeutic activities and the ADL code, because you want to show specifically what type of transfer training you're doing. How did that training differ? What specific cues were you providing for those different surfaces or environments? Double check your entries to make sure, again, that it doesn't appear that you're double billing for any one of our therapeutic tasks that we might be providing. With therapeutic exercise in the treatment encounter note, when you're billing the exercise code 97110, be sure you document why it takes the skills of a therapist for this session to happen. Why isn't this a self-exercise program? Why isn't this something that the caregivers could follow through with? And we do have a skill documentation phrase tip sheet. There's a lot of examples for ways that you can show why it is that you want to be the one providing that therapeutic exercise session or that portion of the session with that person. So look at that phrase sheet for some tips to make sure that's reflecting your sophistication. Make sure that you're showing what skilled services you're doing that a restorative nurse couldn't do. And again, sometimes I see some wonderful skilled phrases, but when I see it day after day after day, it's not so skilled. It gets watered down, it's repetitive, doesn't show the dynamic sophistication of what it is that we're doing. You want to show how you're attempting to get the person more independent with that exercise. So keep that in mind, is how are we trying to progress them to being more self-sufficient, because that is ultimately always our goal. With therapeutic exercise and therapy bikes, items like new steps and omnicycles and so forth, they are not automatically skilled interventions. Your documentation needs to show your clinical reasoning and judgment that resulted in this being a skilled session. So there's also a cycle and bike documentation tip sheet. We want to make sure that we review that and show why it is that we should be billing for that time, or at least a part of that time when they're on a bike, because putting somebody on a bike, letting them pedal away while we do a note, doesn't take our skilled interventions for that to happen. So we want to make sure we're upping our game in that area. And again, make sure that you're documenting the functional reason for this choice of activity, why this is an appropriate exercise for them. So again, what did you alter about today's session on the bike versus yesterday's, and why? Do they show increased or decreased cardiopulmonary tolerance, and therefore you increase the resistance, up the velocity? What is it that you're shifting? Did you monitor the vitals throughout the session? And if so, you want to make sure you document that. And then the education that was provided as feedback, are they stable? Is the blood pressure a little bit high? Is the pulse rate dropping for some crazy reason? So what are we going to do with that information? Did you coach the person on proper breathing techniques or strategies while they were pedaling? And what techniques did you train them, and how did they react to that? Were they able to carry it over? Did they think they were silly? Did they not understand them? Make sure you document that response, because that justifies why we might need to work on it again tomorrow. If they got it 100% the first crack, then we don't need to do it tomorrow, and we've just defeated why we may need to reinforce some things. So show that information very clearly. And make sure you document what aspect of the machine you train the person on to help increase their independence with using a bike. So for example, if there's a biofeedback screen, if there's some game strategies, depending on your piece of equipment, make sure you show what you've trained on. Within the plan of care and the treatment encounter note, you want to make sure that all short-term goals that are on the plan of care are addressed within that 10-day cycle. And even if you didn't treat that particular area, make sure you document why you didn't. If the stair climbing was too aggressive, person doesn't have the tolerance, the balance, weight-bearing status, whatever, to enable those challenges, make sure you note that. Don't look like you're just ignoring certain goals on the plan of care. Remember that a long-term goal should and could also be addressed within that 10-day cycle. All treatment must be related to the plan of care goals or clearly linked to the goal. So for example, if you have a transfer goal, not bed mobility, but you have to address bed mobility to prepare for transfers, then that makes sense. If you have a trunk strengthening goal and you're working on that rolling rotational bed mobility movement to help build that core strength and achieve that trunk strengthening goal, make sure you connect the dots, that it doesn't look like you're addressing one thing when your goals might have been differently. I don't think that there's some things that you can't link. So for example, if you don't have a stair climbing goal, you probably shouldn't be having that person on the steps, because there's really not much you can do to link why you had them go up 3 or 4 steps when there's no stair climbing goal. Make sure you talk to your evaluating therapist about getting that goal if it seems appropriate. And also make sure you're not treating the areas that are noted as intact on the evaluation. If you do find a problem later on, then make sure your evaluating therapist knows that, and they could add in a strengthening goal or a coordination goal, some of those kinds of things that may not have been an issue upon eval. Make sure that you're documenting for the plan of care goals. Double check that goals tab. This is a screenshot within the POC or the POC platform from NetHealth. Make sure you look at the goals tab, look at that goal, link your interventions to that. Make sure you've addressed all of those goals within that 10-day cycle. So some quick ideas for skilled interventions. Don't frequently use the same build phrases. I mentioned this before. You want to be selective and be careful when choosing your build phrases. And don't repeat the same free type phrase very often either. Again, that doesn't sound like you're really using good clinical judgment for each session if you're documenting the same thing day after day. You want to be specific with your strategies and techniques. Don't just say safety training, but break it down. And it might be helpful to say safety training with a focus on. And today you're going to focus on locking the wheelchair brakes. Tomorrow you might focus on pushing up off the armrest of the chair. The next day you might focus on making a full pivot before attempting to sit. So you see how you can focus on things that show your clinical judgment in terms of why you're training them the way you're training, without neglecting those other areas. It's just a focus for that day. The other consideration for documentation is to think about what's going wrong and what your skills, what your smarts are you using to help that person do it better or master it. What goes wrong and what are you doing to help it go right? So draw on your clinical judgment and show that in your notes. Sometimes if you begin a sentence with any one of these words, that's going to help you create a more skilled note. So if you discuss what you adjusted with the wheelchair or the walker height, what you instruct or educate on, what you modified that day, what you might have upgraded or downgraded based on, your findings, what did you adapt? So those kinds of things will help you explain the sophistication of your therapy. Again, with those leading words, starting a phrase with that is going to help you document more specific daily skilled interventions. Note the results of your interventions. Were you effective or not with what you did that day? You might need to do more adaptations to a wheelchair, for example. And again, be very careful to note the caregiver training response as well. That's kind of goes hand in hand sometimes with liability. So if we say we explained it, but they didn't understand it, then that's on us that we didn't do a good job explaining it. So we want to make sure that we do a good job. They say they understand it and they have no further questions, and we want to document that, okay? Regarding patient status, you want to make sure you note the person's status towards the goals at least every few sessions. Only providing a status report, however, doesn't really indicate skilled therapy. So telling me they're min assist with this, 10 feet for that, and mod cues with this, doesn't really tell me what you did to try to help them get better. So make sure you include that information along with their status. And you want to note their status in goal-related terms. And that'll help validate the progress note and help show the gains between progress notes. And I think this is especially important for our speech therapists to do. I think sometimes it's really easy to break down what you're doing, and you might have an overall goal, for example, of intelligibility, but today you practiced pronouncing certain letters or you did some breath support strategies, those kinds of things. Make sure that at least every few days you document how they are doing exactly towards that intelligibility goal. And in those goal-related terms, is it 80% because your goal is for 100%? Make sure in goal-related terms you're giving goal-related status. So our rule book is called the LCD, or the Local Coverage Determination, and it sets the standards that we need to follow for reimbursement. It can limit the number of visits for specific areas of intervention like wheelchair treatments or splinting or modalities. But be aware that those LCD ceilings or limits can be exceeded if we are careful with our documentation for persistent problems. And again, this is where I go back to it's important to document the response to that training. You want to be specific as to the problem that you're addressing and what you're trying to do to help resolve it. So just because they have poor carryover, poor carryover, poor carryover, we need to be the smart ones trying to do something different, documenting that something different to help get them over that learning hump, okay? So groups and concurrent, this is kind of a renewed wrinkle, I guess I'll say, for this now that we're coming out of the pandemic. So for evaluating therapists, you want to make sure that that plan of care includes a justification for why groups and concurrent may be beneficial for this individual. And there's some simple phrases we can do with that, but we want to make sure we justify it. You want to make sure you've included the group code in your initial eval plan of care. We know that we cannot provide group interventions for dysphagia patients. It's only for cognitive communication for that speech code. And our treatment encounter notes need to specify the group type, the skilled service provided within that group intervention, and justifying why that group was appropriate for that individual. And those cues are provided for us, fortunately, in NetHealth when we bill those group codes. We just need to follow those cues, make sure we do a thorough, unique job of documenting that for that individual. We do have on our website some further group information and examples, again, for plan of care phrases and that type of thing. So do check out the employee portal for that information. We have sometimes some tricky situations, I know. We have people who refuse us, and we have sometimes those who are a little bit slow to make progress. So refusals, it's important to document what the person will participate in when you're billing for any kind of therapy minutes. Doesn't make sense to say that you're billing, for example, for ADLs, and your first sentence is patient refused therapy. Then why are you billing a treatment code when they apparently refused treatment? It doesn't make sense. So we need to explain what it is that we did achieve with them that day. And we might educate the person on and be specific. They may choose to not actively perform certain tasks, but that doesn't mean we can't educate them on disease management using those zone tools that are on our website, using any kind of the handouts, reviewing home exercise programs, that type of thing. Or we can document that the person displays limited participation in treatment this date and instruction was provided on. Or the treatment session was shortened this date per patient request and you focused on education regarding, and maybe it's their home setup and what their needs are going to be for getting home. Again, all those discussion things that we have, document that, especially on a day when they may be less inclined to participate. It can help us get through a few of those sessions. For somebody who is delayed with their progress, we want to focus on those small gains. We want to cite any medical reasons for their decline and why we still think they've got the potential to improve. So is it a temporary setback due to a UTI? Do we have new medications coming on board and therefore we expect greater pain management or greater motivation, that type of thing? Sometimes the best we can do is show some small gains with increased tolerances, more stable vitals, more consistent performance of certain things. But when we have that delayed progress that's kind of ongoing for more than a few sessions, We definitely want to talk to our evaluating therapists and consider revising those plan of care goals. We might need to shift the focus to smaller goals. We might need to alter that frequency and duration, and we'd have that discussion with our teammates, especially the FRC. We might be able to note the changes in the person's response to treatment. Like I said, are the vitals more stable at least? And we want to document very carefully all attempts that we've made to vary that treatment so that we can get better results. So do we shift their sessions from afternoon to morning? Are we working in a quiet room or more invigorating room? What is it that we're doing? And I think you guys do this, but we don't always document all the things that we're trying to help elicit better participation or better improvement. Make sure you document that, and that is using your clinical judgment. With our progress reports, progress notes, they are due every 10th visit, and they need to be done by the OTR or the physical therapist for our Part B people and our managed Part B people, managed care people. And we want to choose a build phrase that indicates that we had communication or consultation with the assistant or the evaluating therapist, since that contact is really available kind of almost 24/7 anymore. We would hope we would all have respect each other's privacy and downtime. But again, we can text, we can leave voicemails, we can leave physical notes, we can have that communication so that we can up or downgrade goals as we need to. So make sure that you choose a communication or consultation phrase as part of that supervision section, one of those bottom 5 choices, and that works for both Part A's and Part B's. For occupational therapy assistants in the state of Ohio, if you are within your first year of practice, you do need documented weekly supervision. The co-signing is not adequate. So we do have a paper log that's on the OOTA website. We do have a copy of it on our own employee portal as well. But just make sure that you and your supervising OTR are aware you need to have documented weekly supervision. So be careful with that if you're within the first year. And again, this is a screenshot from Point of Care showing those options for the supervision phrases. And the lower ones talk about communication, therapist completed on-site observation, which does, with the assistant this reporting period, completed on-site consultation, there's phone consultations, many choices that show that you guys have had the opportunity to discuss in each individual. Make sure within the progress note that you address all goals that have been treated that interval of time. If there's no functional changes at the time of this particular progress note, again, consider goal revisions or discharge unless those barriers are resolving, okay? We want to just be very careful using good clinical judgment to show why we think therapy should continue. Remember that the long-term goals may only be updated by your evaluating therapist, and that when they do those updates, they need to be within that prior level of function or justified if they're going above that, I'll say that ceiling or that limit, okay? We want to do standardized testing as much as possible to support the therapy recommendations in each progress report or each progress note. So if there's been a TENEDI or a BERG done on eval or a functional reach test, make sure that we repeat those tests for the progress note so that we can show objective gains. For the skilled portion of the progress note, you want to choose build phrases very carefully and add the specific free type details so that no two progress notes look alike, either from person to person or even within that person's medical chart. The progress note from this 10-day interval shouldn't look like the progress note for the next 10-day interval, okay? Again, make sure you explain any declines in status and justify why therapy should continue. So as a quick wrap up, the point of service documentation that we do or attempt to do as able can save us some time in the long run because it helps residents be aware of their status. It's a great chance to say, hey, what did we do in therapy today? Here's where I think you did really well. This is where we're still having some issues. We're going to address this tomorrow because it's still a problem. But they have a sense of what's going on with their whole plan of treatment. It's not just that they come down to therapy and something magic happens, but here's where you're objectively looking at where they stand. So, and that gives us a chance for some resident input for tomorrow's session as well, so that we know that they love the bike, but they hated, that standing balance challenge or whatever it could be. So again, we have that input for tomorrow's session. Careful, accurate notes are going to protect everybody and everyone involved, both yourself, your supervising therapist, your customers, your residents, Arbor and Aspen. So be very careful with that information. For documentation questions, you can consult either with your area manager, your regional director, your director of clinical compliance, and we do have a ton of resources on our website as well. So be sure you check that out in addition. Thank you for your time and attention.